All right, so for all our speakers, just so you know, you can unmute yourselves when it's time to speak. We can request for you guys to unmute yourselves, but you're going to have to unmute yourselves directly, just so you know. Okay. We'll start in a minute. Welcome everyone else who's joining.
Welcome, Alex. Howard, good to see you, man.
Likewise.
All right, guys, it is 2 o'clock. We're thrilled to have you join us today for our second annual New Frontiers discussion. Really excited to be here. Today, we're going to be talking about CHIP. 3 large areas of discussion for us. Really, you'll find today discussing and revolving around secondary cancers and the relationship with CHIP, the environmental factors and CHIP, and the third being CHIP classification and subtraction in liquid biopsy. So those are the 3 big themes we've put together for you today. I have asked everyone who's on this call, we have muted you. Please stay muted. I think you are able to unmute yourself, but please stay muted through the day. We will be taking questions through the chat. So if you have any questions, please feel free to submit them at any point in these next 2 hours through the chat. We will try to get to them. If we do not get to them during this conversation, we will be putting them up online in our white paper that we'll be publishing over the next couple weeks. The day today, we're going to spend the first hour with 4 excellent speakers, one giving you a general overview of CHIP, the other 3, again, talking about those 3 large buckets and areas. And then the second hour, we're going to spend really discussing with a panel a bunch of different questions that we have come up with, taking some of your questions and discussing them. And then at the end of the second hour, we're going to focus on actually the intersection of all these conversation and BLOODPAC. We host these New Frontiers discussions to really think through, is BLOODPAC as an organization as a whole missing something? What do we need to be adding to our discussion and kind of the areas of interest that we have and the work that we're doing? Is there something within the CHIP conversation that BLOODPAC should be focusing on? Is there a deliverable that we can provide to the community that would be of benefit to the broad liquid biopsy and CHIP community? And so that will be the final kind of area of discussion. So with that, I'm also going to say our first hour will be hosted by Dwayne Hassani, who's going to be leading and introducing all of our speakers. BLOODPAC co-scientific co-chair Jim Godsey will be leading and addressing the second half of the conversation around the panels, as well as kind of where should BLOODPAC go next. So I think there are a lot of people joining. I'm going to stop talking now. I'm really, really excited. And I have to say a special thank you to Medea, my colleague Medea, for really putting all of this together and working so hard for so many weeks on this. Thank you. And with that, Dwayne, I will turn the dialogue over to you.
Dwayne, you're muted.
You're muted.
Yeah, thanks so much, Lauren. I appreciate the ability to have a forum where we can discuss CHIP. We worked hard previously at Cornell, Tempus, and other forums to push the field forward, but also make CHIP part of the conversation and considering how it is we think about treating our patients, and also working into thinking how we can include this for pharma in general. and how it becomes an important part of one, how we consider patients, and two, the diagnostic workup. So what we have is a group of great speakers we've brought in to discuss this, all of which are strong experts in the field. So I'm going to kick off by passing this discussion over to Alex Bick. So Alex is an assistant professor of medicine at Vanderbilt and a practicing clinician who completed his MD PhD training at Harvard and his residency at Mass General. He's been focused on the cause and consequence of CHIP and has published countless papers in Nature Medicine, and other high-quality journals and such, totaling over 50. And he's recognized by Burroughs Wellcome Career Award, Pew Scholar Award, and NIH Director's Early Independence Awards, lots of awards. His talk is CHIP from an epidemiology to disease mechanisms in blood cancer, cardiovascular disease, and beyond. So I'll kick that over to you, Alex.
Thank you so much, Dwayne, for that really kind introduction and for having me here today, and really for convening this incredible forum of stakeholders. My disclosures: I'm on the scientific advisory board of 1016 Bio. And I'd say one of the really exciting things about CHIP is that, when we think back to what we learned in undergraduate biology classes, we're told that our genome doesn't change, that the genome that we're born with is really the genome we have over the course of our lifetime. Now, I think people who are part of the BLOODPAC community know that that's absolutely not true. Our telomeres change with time. We acquire new somatic mutations. We can give rise to all sorts of different kinds of cancer. But we also have these somatic mutations that are arising even in normal tissues, healthy tissues. And these mutations can cause clonality. We also learn about our mitochondrial DNA, that mitochondria change in terms of the number of mitochondria in every cell, the mutations that arise in the mitochondria. And I think this appreciation of how dynamic our genome is really, one of the scientific areas that's really at the forefront of biology today. And in fact, recently, the NIH has started a very large effort to look at somatic mosaic mutations beyond the blood, inspired by, I think, a lot of the success in the clonal hematopoiesis field. So today, for the next 2 hours, we're going to be talking about clonal hematopoiesis. And I think it's important to keep in mind that clonal hematopoiesis actually means different things to different people. At the most basic definition, you might imagine that there's a somatic mutation in a blood stem cell, which confers a proliferative advantage. But that mutation can actually take a number of different forms. It could be a whole loss of a chromosome, like chromosome Y. It could be a point mutation in a myeloid leukemia driver gene, which is how we define CHIP, or clonal hematopoiesis of indeterminate potential. Or it could be in the form of a mosaic chromosomal abnormality, which is basically a large-scale copy number change or a structural variant. So, for example, you might lose, the P arm of chromosome 9, and that's a well-known change that progresses to malignancy. And all of these different kinds of genetic changes can cause clonality and can cause clonal hematopoiesis. Digging into CHIP a little bit more, the World Health Organization classification of blood cancers just came out in the past year, the 5th edition, and decided to formally include clonal hematopoiesis and specifically a few subtypes as specific disease entities. So clonal hematopoiesis of indeterminate potential, or CHIP, is defined as having a couple of features. One is that there's a driver mutation in a gene that causes myeloid blood cancer. And this is important because there is also, point mutations that can cause lymphoid, malignancies, which can also cause lymphoid clonal hematopoiesis. But these different kinds of clones have different disease spectrum. Second, for somewhat historical reasons, CHIP is defined as having a variant allele fraction, or percentage of the blood, of more than 2%. And the backstory is that when people were first going about studying CHIP in papers in 2014 and 2015, they were using exome sequencing, basically 100x exome sequencing. And so clones that were smaller than 2% couldn't be sort of reliably detected. And so that's sort of where this definition comes from. But there's nothing really magical about 2%. You know, a 1.9% clone or a 2.1% clone, you know, probably do about the same thing. And the other part of the CHIP definition is that they don't have other blood abnormalities, which might suggest some other kind of disease. Now, this is in contrast to another acronym that's really a mouthful called CCUS, or clonal cytopenia of undetermined significance, which from my perspective just means CHIP plus an unexplained cytopenia. But for people who are really excited about this and want to get into the weeds, I recommend a review article that was just published online a few days ago by a really expert group that sort of go through the nuance of what is in this WHO classification. And this is, again, I think a really great resource for just getting into the weeds of all the definitions. One of the initial observations was that CHIP is very common in the elderly, and it has this sort of characteristic age-associated prevalence. Now, what I'm showing you is data from the NIH All of Us research program. It's about currently about 250,000 whole genomes. And so these genomes were sequenced with, you know, what is considered high depth from a genome perspective, but very low depth from a cancer perspective. So these are about 38x genomes. And so the clones here are roughly clones that are more than about 5% of the blood. And so the deeper you sequence, if you use a targeted sequencing assay to really identify CHIP at 2%, the prevalence is actually even higher. But roughly speaking, you can imagine that about 10% of people, once they are in their late 60s, early 70s, have CHIP. And if you consider other forms of clonal hematopoiesis, that number is actually even higher. There was a fabulous paper by a group at Regeneron about a year ago that looked in UK Biobank and sort of classified a number of different associations. Many of these had been independently identified by other groups, and CHIP sort of not only associates with blood cancer, but has also been linked to sort of a very diverse set of diseases. Coronary artery disease was one of the first sort of observations in 2017 that CHIP not only associates with blood cancer, but also associates with things beyond that. And then there's been sort of a cottage industry, of which I'm guilty of being part of looking at a number of other diseases that CHIP associates with, including kidney disease, COPD severity. And interestingly, there's been a series of papers suggesting that CHIP is associated with development and worse outcomes in patients with solid tumors. And what I think, from my perspective, all of these things have in common is inflammation. That there's a subset of CHIP genes that seem to cause inflammation, and that makes a number of different pathologies linked to inflammation worse. Now, there's also contrarian views. So, for example, recently, a couple of weeks ago, a team led by Simon Stacy and Florian Zink at Decode, which is part of Amgen, produced a new way of looking at clonal hematopoiesis, and reported that they find no evidence that clonal hematopoiesis was associated with cardiovascular disease. And again, they're not the only ones who have put out papers like this. Usually, the devil is in the details in the way that clonal hematopoiesis was defined. And so, in particular for this Decode paper, their method of detecting clonal hematopoiesis is pretty much able to detect many different kinds of clonal hematopoiesis, not just the myeloid driver kind. And beyond that, there may be some other differences compared to what we've done in the past. So again, for people who are really excited about delving into some of these details, we put up a preprint sort of sharing our observations related to their observation. I'd say what the field largely can agree on, beyond specific associations and specific data sets, is the myeloid malignancy risk of CHIP seems to be different depending on which driver gene. And this is why it's so important to understand how CHIP is being defined in a given data set. And so in particular, DNMT3A, which is a methyltransferase, which is perhaps the most common CHIP gene. About half of patients with CHIP have a DNMT3A mutation, has very little increased risk of myeloid malignancy. And in contrast, TET2 or ASXL1, which are also involved in epigenetic regulation, seem to have sort of a modest increased risk. But if you start looking at genes involved in splicing or genes that are sort of signaling molecules like RUNX1, these kinds of genes have a markedly increased risk of malignancy when you have CHIP. The other factor that has been, again, very consistently observed by individuals in the field is that the size of the clone matters. That if you have a really big CHIP clone, the clone that's making up more than 20% of your variant allele fraction, which is actually 40% of your blood cells, if it's a heterozygous mutation, those individuals are at markedly increased risk of death, of incident myeloid cancer, compared to individuals who have very, very small clones. And so if you observe that larger CHIP clones have worse outcomes than smaller CHIP clones, then you might hypothesize that faster growth is actually worse than slower growth. It's actually harder to test this hypothesis than you think, because many large-scale biobank studies only collect blood at one time point, or even if they collect a second serial sample, they don't collect DNA because they're stuck in this mindset of the DNA doesn't change, so why would we collect multiple time points? We collaborated with a group of talented investigators in Australia who had a clinical trial that was looking at the impact of aspirin on health outcomes in elderly individuals, and they actually did have a second time point measured about 3 years later. And this was work that was published or presented at ASH last year. We tried to divide up, the world of clones, not just by how big the clone was, but how fast they were growing. And so if you considered the cumulative hazard of blood cancer in clones that were, not, doubling in size, but staying about the same size, again, we could see this very nice gradient of larger clones seem to have worse outcomes. But if you compare that to clones that seem to be sort of rapidly growing, those clones seem to, that more than doubled in size over those 3 years, seem to have, markedly worse outcomes. And if we compared that to a set of CHIP clones that not just stayed the same size, but seemed to shrink over the course of the 3 years, those clones really were not ones that one seemed to really have to worry about. And so understanding this CHIP, not just as a static time point, but as a dynamic risk factor, is something that we're still working to understand. But I think the implication is that in the future state, if and when one routinely assays for CHIP, it may not be a one-time measurement. Our research group from an academic perspective has been very interested, not just in what the consequences of CHIP are, but also what causes CHIP. And we and others in the field have found both factors that are sort of intrinsic to the hematopoietic stem cell, as well as selective pressures that act on the hematopoietic stem cell as being causes of CHIP. And so this might be in terms of DNA damage, such as aging or smoking or being exposed to radiation. Being an astronaut flying in space, you might get more radiation, or that might even just be radon from your basement. Telomere attrition, DNA mismatch repair, these are all sort of underlying cause of DNA damage, which can lead to more CHIP. Our research group has spent a lot of time trying to find other pathways using the germline genome, and certainly germline genetics also contributes to CHIP. As well as I think we'll hear from other speakers some selective pressures. So we're really pioneered by Ahmed Zahir, who we'll hear from in a little bit, thinking about chemotherapy and how that affects what CHIP clones grow and expand, as well as other factors like certain immune conditions that deplete your marrow can lead to clonal hematopoiesis, such as aplastic anemia. today, and again, we'll hear a longer talk about this. How do we find CHIP patients? When I see a patient in clinic for CHIP, where are they coming from? Largely, there's two places. One is an incidental finding from solid tumor genetic testing. So for example, this is a liquid biopsy from Tempus, from a patient that I was referred a few months ago, as we'll hear again from Anne in the next talk. Liquid biopsies routinely identify clonal hematopoiesis, and I think many who are part of BLOODPAC are sort of well aware of this fact. Again, depending on what the patient's prognosis is, those patients are often then referred. The other way that we routinely find CHIP today is that myeloid next generation sequencing is performed as part of a cytopenia workup. And sometimes, as happened with this particular patient, the patient has a cytopenia, they get genetic testing, find a CHIP mutation, then the cytopenia goes away, but the CHIP mutation doesn't go away. And so then the clinicians taking care of these patients are sort of interested in, what do we do next for this patient? Work that's been led by Michelle Weeks at Dana-Farber, George Vassalou in the UK, and others have tried to develop risk scores to try and integrate across these different factors. So as I showed you a few slides ago, there's certain mutations that are at higher risk than others. There's certain factors like the variant allele fraction, particularly large clones are worse than small clones. There are other features of sort of the marrow state that you can tell from whether the patient has a cytopenia, whether they have abnormal RDW or MCVs, how old is the patient. And you can put these factors together in a friendly web calculator to come up with a score for your patient, much in the same way that we've been using cardiovascular risk scores to predict outcomes for heart disease. And what we found with Michelle was that high-risk individuals are actually a very, very small fraction of CHIP, that this might be less than 1% of individuals who are at particularly elevated risk. About 10% of individuals might be at this intermediate risk, and about 90% of individuals are at low risk. Individuals who have this particularly high risk feature have a 50% chance of progressing from CHIP or CCUS to frank malignancy over 5 to 10 years. And so this group of individuals are at extraordinarily high risk and might be a set of individuals that we could start thinking about intervening on therapeutically. Conversely, patients who are at low risk are really at quite low risk and not ones that we need to worry as much about in terms of clinical practice. Thanks in part to some of this understanding of risk profiles, and also in part thanks to the existence of drugs for other indications. Although there's no FDA-approved therapies for patients with CHIP, there are clinical trials that are actively enrolling to try and identify subsets of patients with CHIP using different strategies to either target the mutations or to target the marrow environment. And I suspect over the next year, we'll start to see additional trials in this space. Lastly, I'll end with a blog post from Eric Topol, who I used to think of as a cardiologist. Now I think of sort of as a medicine influencer, but was certainly a hero of mine. And he posted a few months ago that he thinks that we are really underappreciating CHIP. He thinks the problem is actually in the branding, that maybe if we drop the indeterminate potential part of it, then we might be able to try and make more progress in terms of translating this to the clinic. I'd say it's a provocative viewpoint, but one that I encourage you all to read. So with that, I'd like to thank everyone for their time. Really excited to hear the other presentations and look forward to the discussion section that follows. So thank you.
Yeah, thank you, Alex. Well, that was great. It makes, I think, if you look at like some of the former colleagues I had at MSKCC, they'd agree that maybe you should drop the indeterminate potential part. That's a conversation that's been ongoing in the branding of CHIP. I'll pose this question, in the chat, but with all the diseases that are affected, one thinks a lot about the societal cost of CHIP, with the caution that, associations and causality are not necessarily equal, and the value of drugging it. So, but we'll move on to the next speaker. So this is to introduce everyone to my former colleague at Tempus, Anne Sonnenschein. So Anne received her PhD in genetics from Michigan State. She's been at Tempus since 2019, working on the bioinformatics development across what I would consider much of the core portfolio there. She's been leading development of bioinformatic pipelines for CHIP detection there in solid tumor and liquid biopsy. We worked together on an ASH abstract that was presented last year in this space, mostly in solids. And her talk is entitled Bioinformatic Strategies for Identifying Clonal Hematopoiesis in NGS Liquid Biopsy. Anne?
Thank you, Dwayne. Just to confirm, can people see my slides?
Yes.
Okay. All right. Thank you for that introduction. In this segment, we're actually going to pivot a little bit to focus more on CHIP as noise rather than CHIP beyond the noise. At Tempus, we've been working on methods to screen CHIP variants in liquid biopsy testing for cancer patients. Targeted sequencing of plasma for circulating tumor DNA is a very non-invasive method for precision medicine, and it's becoming increasingly sensitive. These assays frequently screen for small variants, SNPs and indels in genes like KRAS and TP53 that are known to be associated with cancer. This field has been moving towards higher and higher levels of sensitivity. MRD testing is starting to drive the field down to sensitivities as low as 0.01% allele fractions. To just give a brief overview of how Tempus fits into this, we have a number of different assays. The main one I'm focusing on today is our XF Plus assay, which is a plasma-based assay for detecting variants down to 0.1% allele fraction. I'll also briefly be mentioning XF Monitor, which is a new offering. It's an algorithm for estimating tumor fraction in plasma samples. And then I'll also be using some data from XT, which is our solid tumor assay. This is a sequencing assay for solid tumor biopsies, usually paired with matched healthy blood from the same patient. All right. So in addition to being medically and scientifically relevant in its own right, CHIP is a major confound for this type of testing. This is most saliently the case with TP53. So this is data taken from JISPL 2020. This is the distribution of the genes in which the CHIP variants occur in 4,000 people. So as Alex Bick mentioned, it's pretty overwhelmingly concentrated in DNMT3A or DNMT3A, TET2, and ASXL1. So these three together are frequently called the DTA genes. These three genes are not hugely relevant for most cancer types. TP53 is less common for CHIP, but it still occurs at an appreciable frequency, and this is possibly the single most important gene for most cancer types. It's the most frequently mutated pan-cancer gene. So even though this is not the most common form of CHIP, as a confound in liquid biopsy, it's probably the most important. The degree to which this is a confound is heavily dependent on how deeply you're sequencing. So CHIP is generally considered clinically relevant above 2% allele fraction. And this is seen in about 10% of people over the age of 70. When you start looking at clones that are lower than 2%, it starts being more common, and it starts being more common at younger ages. So down to 0.1%, you can expect probably 20% of healthy adults to have a CHIP clone that's detectable at this allele fraction. When you start going down to the MRD levels of 0.01%, this is going to be ubiquitous in healthy adults. Maybe not 100%, but very close to 100% of the people you sequence will have a detectable CHIP clone at that level. But we are mostly focusing on 0.1% for this presentation. So how do you identify CHIP? So the sort of gold standard for identifying CHIP and distinguishing it from tumor variants is having matched white blood cell data. So this figure on the right is stolen from MSK. These are variants that are detected in plasma DNA. On the x-axis, it's their allele fraction in plasma, and on the y-axis is their allele fraction in paired white blood cell data. So we've got our germline variants in the middle. Each dot is a variant, 50% allele fraction in both plasma and white blood cells as expected for germline. The yellow dots along the x-axis are our tumor variants. So these are higher allele fraction in plasma, enriched in plasma, but basically not detectable in the white blood cells as expected. And then we have our orange box in the left corner, probably extending diagonally up to the purple box. These are CHIP variants. They're going to have approximately equal allele fraction in white blood cell and in plasma. So best way to determine if a variant is CHIP, repeat the sequencing in white blood cells and see if the variant is still there. Relative absence in tumor is another really strong piece of information. So tumor variants, even more than plasma, are going to be enriched in the solid tumor. CHIP variants may also be detectable in the solid tumor if there's immune infiltration, but usually not to the same degree. So enrichment in the tumor is a good indicator that the variant is a tumor variant. Longitudinally, CHIP variants fluctuate quite a bit less. So if you have multiple time points in the patients undergoing treatment, you do expect your tumor variants to decrease over time, hopefully in the plasma. Your CHIP variants are not necessarily going to respond to treatment or respond in the same way. Another good indicator is that the variant allele fractions for the CHIP may be outliers relative to the tumor variants. So if you have multiple tumor variants associated with this tumor and there isn't a significant subclonal population, they're probably going to have similar allele fractions to each other. There's no expectation that the CHIP variants are going to have the same allele fraction as the tumor variants. In XF+, we usually don't have this information. So how do you identify CHIP if you do not have white blood cell data available? You do not have solid tumor data available, and this is potentially the first time you're sequencing a patient. So there's a number of different features that can be and have been used for identifying CHIP in liquid biopsy. I'm going to go over each of them, and I'm also going to present some sort of exploratory analysis data. So we're going to look at 600 pathogenic variants that were sequenced in XF+, where we do have XT data available. We do have matched solid tumor and white blood cell data, so we know if they are tumor or CHIP in origin, and we'll see how effectively each of these features that we discuss classifies them independently and together. So the most standard method is just look at the gene. So CHIP is overwhelmingly in DNMT3A. And if you expand that out to the 5 most common CHIP genes, you do exclude a lot of CHIP variants. So if you just say any variant in these 5 genes is CHIP, any variant outside of these 5 genes is a tumor variant, you get pretty accurate classification actually. So of the 600 pathogenic variants, and this is approximately a balanced data set, 50 CHIP, 50% tumor, we accurately classify 83% of the variants. So that's quite high for such a simple method. But notably, this is not balanced performance. So I'm calling it tumor variants negatives here and CHIP variants positives. This is very high specificity and very low sensitivity. We correctly classify 98% of the tumor variants as tumor. So very, very few tumor variants in these solid tumor patients are in these genes, but we are only correctly classifying 2/3 of the CHIP variants. So 1/3 of the CHIP variants are not in these genes. And to some extent, probably the most clinically confounding CHIP variants, the ones in TP53, definitely not included or correctly classified this way. So in terms of raw numbers, this is pretty good performance. In terms of actual utility, we need to do more. Okay, another slightly more sophisticated approach people will take is they'll look at the historical prevalence of an individual variant. So something people will commonly do is look in Cosmic and see, has this variant been seen in heme samples? Has it been seen in lymph tissue? Is it a blood cancer variant? Or is this most commonly associated with solid tumors, specifically the tumor type that this patient has? And excluding variants that are associated with heme and only including variants that are associated with solid tumor would be a good approach if mutations were predominantly one or the other. Unfortunately, in the case of TP53, this is rarely the case. So the most common TP53 cancer mutations are also some of the most common TP53 CHIP mutations. So on the right, I have a plot of how often we see these variants as CHIP and how often we see these variants as tumor in Tempus's database. So one of the most common TP53 cancer mutations, 75% of the time we see it, it's tumor. 25% of the time we see it in our sequencing data, it's actually CHIP. So this is very ambiguous and it's an important variant. So if we just say, has it been previously seen as CHIP, we do correctly exclude about 90% of the CHIP variants, but we're still missing 10% of them. And we are also hitting accuracy of 32%. We are really excluding the majority of the important tumor variants. So people will sometimes use more sophisticated approaches than this. The Novartis model from 2023 incorporated both the historical tumor prevalence and CHIP prevalence as separate features in their model, and we think that's a really good approach. I previously mentioned that one of the sort of gold standard features is that you expect your tumor variants to be similar allele fractions to each other. You expect your CHIP variants to potentially be outliers. So our XF monitor algorithm takes into account the allele fractions of the tumor variants to propose a tumor fraction estimate for a given plasma sample. Our tumor variants correlate quite strongly with this tumor fraction estimate. Our CHIP variants do not. So on the right here, each dot is one of the 600 pathogenic variants. Dark blue are tumor variants, light blue are CHIP variants. The x-axis is the allele fraction for each of these variants, and the y-axis is the tumor fraction estimate for each of these patients. So the dark blue is correlating very strongly. The light blue is not correlating whatsoever. So if we just train a model on a different set of 600 variants, using as the only inputs the tumor fraction estimate and the allele fraction of the variants, we get pretty strong performance actually, which isn't terribly surprising looking at this plot. So this accurately classifies 74% of the variants. And this is very balanced. It's accurately classifying about 74% of the tumor variants and about 74% of the CHIP variants. The ROC-AUC just using this information is 0.82. And this is completely naive to gene or variant historical prevalence. The place where this is probably failing and the reason why it's not 100% is this bottom left corner. So variants that are low allele fraction in samples with low tumor fraction, which is unfortunately very common for both the CHIP we're detecting and the patients that we sequence. It's very difficult to distinguish just based on this information whether or not a variant is tumor or CHIP. But this is a very powerful feature. Another feature that has attracted a fair amount of excitement recently and is also very powerful is the information about the fragment size of sequencing reads that contain tumor variants in plasma. I'm not going to get too much into depth on this, but cell-free DNA that's from a tumor has a very distinctive fragment size distribution, while CHIP variants look much more like germline variants, or much more like the reference alleles that are seen in the sequencing reads. So on the right, this is again how this looks on our 600 pathogenic variants. The median for tumors is shifted a little left relative to CHIP or germline variants, and the alt reads versus ref reads are much more similar for CHIP and germline than they are for tumor. So just inputting these features, information about the fragment size distribution into a model, training it on 600 variants, testing it on a different set of 600 variants, we correctly classify 83% of variants. And again, naive to any other features, just using fragment information. The ROC-AUC is 0.91. So this is even stronger than the tumor fraction estimate, though both are very strong features and they're totally orthogonal to each other. This is probably also suffering a little bit at low allele fractions because when you have fewer reads, fewer alt reads, you don't have as much information to form this distribution. But this is by itself a very strong feature. So we've discussed 3 categories of features that are all actually independently quite strong and totally independent of each other. So if we combine them, of course, we reach 200% accuracy. We don't. We reach very high accuracy. We have submitted this as an abstract for AACR, so I can't give the exact numbers, but we are, in terms of ballpark, we're beating 90% accuracy, and our ROC-AUC is above 0.95. So this is pretty strong. Ensemble models that incorporate multiple orthogonal features are quite strong. As a note, though, we're not quite at parity with something that's solid tumor informed or white blood cell informed. So Dwayne showed in his talk for BLOODPAC in September, a model performance where you incorporate white blood cell data as a feature, and you reach an ROC-AUC basically of 1. You reach accuracy that's close to 100%. We repeated that, got the same result. If we incorporate solid tumor information, it's basically the same thing. It's not quite as good as white blood cell data, but it's pretty close. This ROC-AUC is above 0.99. So our plasma-only model is not quite this strong. We are not at parity with something that's not plasma only. And part of this is probably because there are some challenging variants that are very difficult to classify with any of these features. And some of those challenging variants are some of the most important ones. So variants outside of the DTA genes, where you can't just say it's in DNMT3A, it's CHIP. Variants that occur as both cancer drivers and as CHIP variants. Variants that are close to the limit of detection. And in samples with low tumor fraction, these are the challenging variants, and we really need to characterize. When we characterize our models, we need to remember we have a 66% boost from just gene alone. And we need to know what our performance is on challenging but clinically relevant variants. So circling this back to the themes of this seminar, how much common cause is there between CHIP identification and CHIP exclusion? They are definitely very different use cases. The sensitivity needs are really, really different. 2% is kind of an arbitrary like CHIP minimum, but the clinical relevance of a CHIP variant at 0.01% allele fraction is probably not extremely high, though I guess we don't know since we don't have a lot of that data yet. But for cancer patients, our sensitivity at detecting CHIP needs to be really, really high just to exclude it. In terms of specificity, the consequences of a misclassification are totally different. If you misclassify in a healthy person a variant as CHIP, you've probably misclassified a germline variant or a sequencing artifact, and that will have consequences. But compared with in a cancer patient misclassifying a potentially therapeutically informative TP53 variant, that is extremely a critical error. You have to have a false positive rate essentially of 0 for that type of variant. In terms of what are gold standard reference sets that can be developed that encompass both use cases, the needs for plasma model development are probably more stringent than the needs for reference sets for CHIP in healthy populations, but we would definitely love reference sets that encompass both use cases. Another big question we're sort of thinking about at the moment is, we're detecting CHIP in plasma. What do we do with it? What level of accuracy do we need to have before we can say we share this? At what allele fraction do we think physicians will find this relevant or useful? What do we do with this data now that we have it? And I know this is going to be discussed in the panel discussion, so I am looking forward to that. But thank you all for your time and attention.
Yeah, thank you so much, Anne. Yeah, I think you said it, and I really like the level of technical detail in the talk. It was very interesting to see, you point out and call out all the issues that are involved. I think, a lot of this too is about, what the indication is. So it's a matter of, what, especially when you focus on, CHEK2 mutations, P53, things that prognosticate or are involved in therapy selection as to, what would be acceptable. So it's probably an important discussion to have later on as to, what's an acceptable number to, say pharma, who has this burgeoning need to enroll patients where tissue is limiting on liquid only. And, are you falsely putting, we use the example of PARP inhibitor therapy often, are you falsely putting people on PARP inhibitor therapy when they have CHIP? And what does that do to your Kaplan-Meier curve on the clinical trial? So thank you. Next we have, it's a great job. Next we have Ahmed Zahir. Ahmed leads strategy focused on near patient blood-based diagnostics for therapy selection, including MRD and early detection at AstraZeneca again. Prior to this, he was director of clinical bioinformatics at MSKCC, where he oversaw development of NGS analysis for tissue and liquid-based tests and was instrumental for all the great assays we hear coming out of that organization. And he currently serves on the Molecular Oncology Committee for the College of American Pathologists. His talk is titled Clonal Hematopoiesis in Solid Tumor Patients, Implications for Secondary Malignancies and Diagnostics.
Thank you so much for the great introduction, Joanne, and thank you for inviting me to speak at this really nice and informative seminar. So I think Alex did a really nice job of going over the background of what clonal hematopoiesis is, and so I won't labor on the point too much. I do want to sort of highlight the figure on the left-hand side from this recent review, which I think is a really nice way of exemplifying what clonal hematopoiesis is over what we call polyclonal hematopoiesis. I think a lot of the times conceptually, what is noise and what is signal it's a little confusing to sort of understand and talk about. I really like this figure to sort of highlight what do we mean by clonal expansion over time versus the sort of background mutations that just occur over time in the hematopoietic stem cells. As we mentioned, there are different types of genetic alterations that causes clonal expansion. I'm going to focus on the SNVs, point mutations, and small indels today. And sort of going into this, my focus is going to be about solid tumor patients. At Sloan Kettering Cancer Center, we developed and implemented a next-generation sequencing-based diagnostic assay called MSK Impact that enabled us to identify mutations, copy number alterations, and stressful variants in over 500 genes. I think one of the differentiating factors or part of this assay is the fact that we sequence both the tumor and the matched blood sample for the patients. And that really enabled us to definitively identify what is somatic for the tumor, what is the germline alteration, and similarly, what is a somatic mutation in the blood, clonal hematopoiesis in this instance. And we were able to identify both mutations and copy number alterations in this population. And I think it was around 2015 or so, through some QA, QC work that we were doing in the blood samples, we started noticing these mutations, and basically all the other large-scale analyses started popping up in New England Journal of Medicine at the time. And so we decided to take a look at this at a cohort level. And we took about 9,000 patient samples and identified the somatic mutations in the blood. And we saw that about a quarter of the patients had clonal hematopoiesis in genes that are commonly mutated in hematological malignancies, such as DNMT3A, TET2, PPM1D, and so forth. At the time, because of the small number of cohort and the difficulty in collecting detailed clinical histories, I think Kelly Coombs in this paper actually had to do chart review of over 5,000 patients individually, which was quite painful for her. We were able to identify smoking and prior radiation therapy as factors that associated with the presence of CHIP. And these selective pressures that led to expansion of the clones. We also further showed that presence of CH increased the risk of developing secondary malignancies in these patient cohorts, with a little bit of sort of decrease in survival probability, overall survival in these patients. These findings really led to the first clonal hematopoiesis clinic in the world, as I think, as far as I know. And we started prospectively reporting CH mutations to our clinicians and to patients. This work was led by Ross Levine and at the time Kelly Bolton, who's now at Washington University leading her own research group. And this clinic really was put together to, review patient results, figure out what we need to do for patients. Do we follow them? Do we, do hematology workup to figure out whether there is an underlying hematological malignancy that the patient isn't aware? And I think it generated a lot of learnings and knowledge for the community as well. Of course, over time, we sequenced more samples, and we wanted to sort of identify and refine how oncologic therapy actually shapes clonal hematopoiesis in cancer patients. For this, we created a cohort of almost 25,000 patients with deep phenotypic data. This time, Kelly actually, instead of doing manual chart review, she used her computational skills to do automated data extraction from patient charts. And we were able to identify, CH mutations in this cohort with an updated algorithm. And what we saw is that between treated and untreated patients, the rate of CH overall rate of CH may not be too different, but the underlying difference was actually driven by what we termed CH-PD mutations. In this instance, PD means presumptive drivers. So these are mutations that are known to drive hematological malignancy transformation. And those are the ones that have a higher rate in the treated populations. We were able to specifically look at the sort of three main factors that we knew to associate with CH. In this instance, aging was associated with all the genes that we looked at. Therapy, on the other hand, was associated with CHEK2, PPM1D, and P53, so the DNA damage repair genes. And smoking, interestingly, was associated only specifically with ASXL1 mutations. Because of the deep phenotypic data, we were able to pull this up a little bit more and specifically look at therapy. In terms of looking at systemic therapy, we saw, radionuclide treatment, external beam radiation, and cytotoxic therapy were associated with CH, but targeted therapy and immunotherapies were not. Specifically going into the cytotoxic therapies, we saw that topoisomerase inhibitors and platinum therapies are associated with CH. And within the platinum therapies, carboplatin was the driving factor for presence of CH in these patients. Alex made a point earlier that in the biobanks, usually we have one time point of donor-derived DNA. We were lucky enough to find about 525 patients for whom we had two different DNA blood draw time points. And so we were able to compare first of all, ask the question, does treatment promote pre-existing CH or induce new mutations? But also, how does treatment change the allele frequencies or the growth dynamics of CH mutations? The answer to the first question is that about 95% of the CH variants were detected at both time points that we sequenced. And the answer to the second question is, I'm going to show a couple of figures here. What we're looking at are the untreated patients in between these two time points. And we classified or clustered these mutations as the allele frequency going up, allele frequency being stable, and allele frequency going down. We saw that targeted therapies or immune therapies, the sort of pattern was very similar to the untreated patients. However, in the cytotoxic therapy treated patients and radiation therapy treated patients, we saw a vast majority of the mutations going up in allele frequency over time. Specifically, the mutations in DDR genes have gone up in this particular cohort, PPM1D, P53, and CHEK2, relative to the other genes such as DNMT3A, TIT2, and ASXL1. So there's definitely a treatment-driven clonal expansion happening here, and the clones that expand have specific mutations as well. Next, we asked whether the pathogenic or likely pathogenic germline mutations could have also a sort of selection process for CH mutations. And these pathogenic, likely pathogenic mutations I'm talking about are the ones that are predisposition mutations for solid tumors, not necessarily hematological malignancies. And so in a cohort of about 47,000 mutations, we've identified germline mutations and clonal hematopoiesis mutations. And we saw that amongst the patients with germline and CH mutations, about 10% of them have both mutations. And having a germline mutation was specifically associated with having a CH or a CH presumptive driver mutation. There is, I think, a little bit of signal for number of CH variants and large clones, but the signal didn't reach significance in this instance. And finally, what we saw was that these germline mutations had an additive effect to the risk of developing leukemia, secondary leukemias in these patients. So, you know, you have your baseline of CH mutations. Early Papamaniolus groups had shown that CH mutations and mosaic chromosomal alterations had an increased risk. And what we see is that there is potentially an ever-increasing risk when you have a germline mutation as well. Again, the overall numbers with secondary leukemias were small, so it made it a little hard to make definitive conclusions from the study. And taking a little bit of a different approach here, another question I want to talk about is the implications of CH mutations in solid tumor diagnostics. I think Anne did a brilliant job of touching upon some of the things I want to talk about here as well. I'll start with a study that we did looking at the confounding effects of CH mutations in solid tumor patients, in solid tissue testing. In this instance, we had a cohort of about 18,000 patients, and we identified CH mutations. And in the pink here, you're looking at the allele frequency distribution of these CH mutations. In the blue, I'm showing the same mutations, but their allele frequencies in the tumor sample. So these are not somatic tumor mutations, they're just CH mutations, but their allele frequencies in the tumor. Majority are 0, but you do see some with higher allele frequencies. And so we asked in this cohort, if we didn't have the blood sample, how many of these mutations we would have signed out as a somatic tumor mutation in the clinical report. And the number is around 1,000 mutations, comes up to about 5% of the patients, not an insignificant number. I think. And at the time, we termed these CHST, CH solid tumors. I think we all love to label and name our findings. CHST mutations have a similar prevalence to regular CH mutations, so surprisingly, I think. And they have different rates of prevalence across different cancer types. We did observe a significance in skin cancer and lung cancer, but I'm not sure what the biological reasoning is here in this instance. Given that these mutations occur, we're observing them in the tumor because of blood infiltration. I'm not sure if in this particular cancer types, there is a higher levels of blood infiltration relative to the other cancer types. Again, not so surprisingly, we see these mutations occur in similar genes to CH. What was surprising to us and to me was that most of these mutations were absent from population databases. So if you're going through the effort and sort of using, Cosmic, for instance, to identify what might be a tumor mutation versus not, Exact and Nomad weren't really useful in this instance. And what we saw was that over half of these mutations were labeled as oncogenic or likely oncogenic through OncoKB database, suggesting that if you see this mutation, you're probably going to report it because it's going to become an important mutation for the patient. One interesting example in the study that we observed, and I think it sort of relates to some of the conversations we had earlier, is this BRCA pathogenic mutation. When we look at the data from the tumor side, allele frequency is 11%. So if you didn't have the blood, if it was a tumor-only sequencing, I think we would have reported this mutation. In the blood, it's at 34%. Again, if we didn't have the tumor mutation, if this was a germline test, for instance, we would have reported this as an inherited germline mutation. When we have data from both, and we're looking at it together, we presumed first, maybe this is some sort of loss of heterozygosity happening in the tumor. And that's why we're seeing the allele frequency at a lower percentage here. We looked at allele-specific copy number data, and we saw at the BRCA2 locus that there is no loss of heterozygosity. Actually, both copies are present, further complicating the situation here. We were lucky to obtain additional specimens from the patient. And so we obtained saliva, buccal swab, and a normal colon sample. And that enabled us to definitively show that this mutation actually is a CH mutation, and it's not a tumor mutation, it's not a germline mutation. And I think, if this patient was eligible for PARP inhibitor therapy, they probably would have gotten the therapy given the sort of they would have gotten the therapy if it was only tumor sequencing or if it was a germline sequencing, but looking at data from both sides definitely prevented that from happening. Very quickly touching upon liquid biopsies, utilizing white blood cell sequencing data, we can definitively identify what mutations are originating from what tissue, and sort of talked about this figure as well a little bit. From a cohort of 617 plasma and white blood cell pairs, we used an assay we developed at MSK called MSK Access. What you're seeing here is on the x-axis the allele frequencies from cfDNA, and on the y-axis is the allele frequencies from white blood cells. And we have created sort of these 4 different clusters. What's important is the sort of group of mutations in number 4, where we can show that up to 77% of the variants were removed through use of white blood cell data. And these are hundreds, if not thousands of mutations, really making it hard to identify the source of without having white blood cells. One thing, again, and touched upon, I'll mention here as well, is the fragment size differences between tumor-derived mutations and non-tumor-derived mutations. The mutations that originate from blood cells, CH mutations, tend to not have a difference in terms of their fragment distributions. But as Anne also mentioned, we had a couple of examples where, a KRAS mutation in a lung cancer patient, for instance, would have a mutation, would have 3-4 reads supporting the mutation. Can't really create a distribution with that low number of reads to sort of infer the source of these mutations, and in this instance, white blood cell sequencing helps definitively. And lastly, I'll touch upon this study that came out earlier in the year utilizing data from about 1,400 SNVs. They've generated a list of variables, a variety of variables, and trained a logistic regression and random forest classifier to ask whether they can use machine learning approaches to differentiate CH mutations from tumor mutations. And the overall success is about 90%. And what was interesting to me is the variable importance plots that are shown here. Allele frequencies seem to be the most important factor for both of the machine learning methods here, followed by gene name and the mutation signatures. Although interestingly, on the right-hand side, I see EGFR as an important gene, which isn't really necessarily a CH gene like some of the other genes that we've talked about. Unfortunately, this data lacks use of fragment size information, so I think combining both would have been a really nice way of looking at it as well. And I'll conclude with this same figure that I showed on slide 1, which I think, again, is highlights what is noise for our diagnostic purposes and what is actual signal for finding and selecting patients who are at high risk for developing hematological malignancies. And I'll finish with these remaining questions for our community here. We talked about using CH as a biomarker to identify high-risk cancer patients. How do we do this? How would this look in practice? And can we treat these patients prophylactically, actually? What is the most optimal way to identify and remove chip variants or chip-derived noise in liquid biopsies in the absence of WBC sequencing? And majority of the mutations in chip occur in methylation machinery. And so how does presence of chip actually lead to potential, or does the presence of chip lead to epigenetic changes, further confounding methylation-based liquid biopsy assays? And what is the extent of chip confounding in the setting of MRD? With that, I'll thank the organizers again. I thank all of you for listening. Thanks.
Yeah, thank you so much, Helmut. Great talk as always. So I'll pose in the chat. I think, the nice question it brings up is it important to think about indications where white blood cells are indispensable, like in low shedding tumors where you have very little read support. Another interesting thing about your closing comment was the power of referring to methylation and epigenetic signatures, where you'd think that epigenetic and methylation-based tests would be robust to chip if properly trained, age matched, balanced, etc. That those features would be excluded in selection, and that would benefit MRD tests. But then also is chip something you should circumvent? So you can imagine cases where, just like there's a BAL signature for an enable-like signature in ALL, there's an underlying methylation pattern that still lets you discern the underlying chip mutation in methylation data, so on and so forth. So all great discussions that we don't have time for. So I'll move on to Mary. So Mary Brophy joins us. She's a hematologist at the VA Boston, assistant professor of medicine at Boston University, a co-founding director of the Maverick program, so heavily involved in VA activities on the development and execution of VA's research and precision oncology program. So without further ado.
Great. Can you see my slides?
Not yet, Mary.
Oh, let's try this again. Sorry about that, guys. It's can you see them now?
Not yet.
Mary, do you want me to? I have your slide.
Yeah,
right
why don't we just do it that way?
there. Okay, give me one sec. Let's see.
Okay.
Share screen. I'm going to make this full screen mode. There we go.
Okay, great. And if we could just go to the next slide. I have no disclosure. So I'm Mary Brophy. I'm actually going to be talking on the clinical perspective of clonal hematopoiesis as a general hematologist, speaking about this and sort of bringing all of this into the framework. So if we can go to the next slide. So in 2022, based on next generation sequencing, there's been a realignment and a reclassification of myeloproliferative diseases and neoplasms. With this new category added, the myeloid precursors, and clearly a lot of the findings related to next generation sequencing of findings come from the fact that we have found these in these neoplasms. So there's mutations, somatic mutations occurring in these neoplasms that now we're picking up in routine blood and providing us with these precursor classification, which is really a new phenotype for us in hematology. So next slide. So this classification going through it, as a clinician, the formulation of this new classification is based upon, not having a hematologic disorder in CHIP. So there is no hematologic abnormality. It's being defined by the presence of a somatic mutation, and that somatic mutation is the defining feature of it is get some background noise here.
We had to go very high. We had to go very, very high up with the snowball.
So-
fields.
There we go.
Mary, I think you're muted again. Hold on.
Am I back?
There you go.
You're
You're
back.
back.
Yay! All right. Sorry, I've been chatting away here. How far back am I off? So, anyways, with new next generation sequencing, we've defined this new phenotype. No hematologic disorder coming from our organ and blood. Somatic mutations that we picked up by looking at our myeloid neoplasms and defining it basically on this variable immune frequency of 2%, which is a limit of what we can adequately detect in some of the testing that was done. So if we look at this clinically, this new phenotype, the prevalence of it has been shown by Dr. Bick. It goes up with age of CHIP. But if we look very deeply, this variable immune frequencies at much lower percent levels, it's ubiquitous with age. This is an aging process. Just like your skin ages and you develop lesions on your skin that are pre-malignant lesions based upon exposures, because it's a rapidly proliferating cell type that has to adapt to the injury. Our blood, which does the exact same thing as our internal defense mechanism as part of aging, develops these mutations. The issue is clonal hematopoiesis also, if we look at it from exposure, what put people at higher risk for having this along with age, there are exposures that make it much higher, and those have been discussed, the cytotoxic chemotherapy and the ionizing radiations. So really here what we have is nothing new in the way of a paradigm of having a germline genomic background that puts us at a variable risk, baseline risk for developing a malignancy, exposures that increase that risk, that make clones available, more generation of more clones, that brings you to a level of mutation that if you cross over into it, you develop a malignancy, the paradigm of developing a malignancy over time. So CHIP is associated, and we know, with a decreased overall survival, increased risk of hematopoietic malignancies, cardiovascular complications, and compared to age mass controls. But if we step back and look at this, the increased mortality is really occurring in people over the age of 70, not younger individuals. And the excess mortality in this is being driven by cardiovascular events rather than neoplastic events. So on the clinical side, it's older patients that have CHIP, but they're dying of other causes, often cardiovascular and etiology. Next slide. So as Dr. Bick already pointed out at the beginning, it's associated with this increased risk of transformation to myeloid malignancy. But again, if you look at it on the clinical side, only a small fraction of individuals with CHIP will develop these hematologic malignancies. The risk of evolving is about 0.5 to 1% per year. If you look at the prevalence of CHIP in 70-year-olds, it's 100 times fold higher than developing actually MDS or leukemia. And the risk factors for developing it, as shown by Dr. Vick, is there's numerous risk factors, next slide, that have been put into a risk calculator. And we can look at the population of risks. There's actually, I think we skipped the slide there. Yep, thank you. There's a clonal hematopoiesis risk score that has been developed. But if we look at the risk and breaking down into the categories and what percent of patients fall into those categories, the overwhelming majority is in low risk, and survival is almost is 93%. And as you go up and in risk, really only a very small population is at really high risk for the transformation to a leukemia, and that 10% survival in that group is still about 50, drops to about 50%. So let's move to the next slide. So what's new here? We have a new biomarker in the myeloid series that's giving some idea of our risk for developing malignancy and death. But if we go back and just look at our other side of the hematopoietic side of the picture, the lymphoid side of the picture, clonality, where we have much easier ability, particularly because of the B cells, to be able to look at the at clonality at earlier stages because of the markers that because they produce things like immunoglobulin, and they can be immunophenotyped by flow cytometry to be monoclonal. We look at this model, it's exactly the paradigm, the same paradigm we're seeing on the myeloid side. So Mugus has been around, or an SPEP has been around for decades now, and a predictor of finding this monoclonal gammopathy of unknown significance, in which the prevalence follows identically with the what we've seen in CHIP, that it occurs more in older ages. The median age of detection is an older age. Lifetime progression is small, about 10%, only 1% of patients per year. Virtually all of the patients, at least with multiple myeloma, that go on to develop across that paradigm to become a malignancy, only about all of them, virtually all of them have this pre-clonal mugus present, and it stays in fidelity with the clone. So if you have an IgG clone, you go on to develop IgG malignancy of myeloma. The median overall survival is shorter, only slightly shorter than age-related match controls. So what does this mean in sort of the clinical picture of it? What have we learned in 20 years or 40 years of monitoring monoclonal gammopathy, where we have a similar risk score that shows a relative risk of developing it? Majority of patients, again, low risk, small percentage of the patients, 4% being high risk. The absolute risk of progression over years small, except in the high risk patients, and the absolute death when you correct absolute risk when you progressing when you correct for death because it's occurring in older patients with other comorbidities, cardiovascular particularly. These patients die from other causes or competing causes. So if we look at this, we say, okay, what have we learned by monitoring over the years these patients with monoclonal gammopathy? It's not a screening test. It's not recommended as a screening test. It is one that we do because there's a clear indication, an indication. There's a hematologic abnormality. There's a neurologic abnormality. There's some sort of inflammatory disorder in the rheumatologic pathway. There's kidney damage that makes us and pushes us to do this testing. The same thing in monoclonal gammopathy. B cell lymphocytosis, monoclonal lymphocytosis, in which there's a lymphocytosis. There's some kind of marker that's pushing us to do the testing. There's no prospective studies of proven benefit in this monitoring. And if we look at the observational studies of cohorts over the years, what we see, what's the return on investment of doing this? What we've seen is that really the improvement in survival and in decreasing morbidity from having this clone comes from is only seen in those patients who have progressed to the malignancy. And it's unclear whether that benefit is really coming from early detection of the clone versus just some lead-in time bias. And the reality is, because of the toxicity of the treatments, we don't treat until you cross right now. And the paradigm is not to treat until you cross over, even as we see you moving up in risk for for development of the malignancy. So, when we talk about CHIP and the testing for it, it's a new biomarker, a new phenotype that's been defined on the myeloid side, coming from the same hematopoietic stem cell that we've had years of experience on the lymphoid side in following. And so, what's the return on investment in doing this testing on the clinical side? So, if we could flip to the next slide, please. So, we have to look at the um, return on investment and being what's the indication for this testing on the clinical side right now. We've had a lot of great talks up to this point talking about it's again incidentally happening. It's being picked up as people are being biopsied for solid tumors. It's being picked up because genetic testing is already being done on blood samples. Maybe as we do circulating tumor DNA testing, we're going to pick up more and more of these cases, but they're incidental findings on these individuals. And if we look at the paradigm of taking MDS as the clonal disorder and where all these things overlie, again, this chip could be much broader than this. There's immune industry. There is an overlap with these autoimmune related disorders that occur. And if we think about our rheumatologic colleagues that deal with a lot of the immune system, they follow the same paradigm of older patients, inflammatory diseases, high risk for cardiovascular disease and death from cardiovascular disease, increased risk for development of malignancies and clones. So this inflammatory paradigm that exists in these myeloid malignancies are there. So in sitting back and thinking about it as a clinician, I'm saying to myself, what is triggering, what are the indications that are currently being used? As I said, right now, there's usually a phenotypic presentation outside of the testing that's being done for other reasons on doing the tumor testing or doing germline testing that we see this. It's in the cusp, right? The C cusp, the cytopenias that are there. But are there other areas where we should be looking? And I think this has been brought up in discussions that have been going on right now. Are there environmental issues that put people at higher risk? There is a germline baseline, there is an exposure. And we know these high level of exposures from exposures such as chemotherapy and radiation put people at higher risk for doing this. The question comes out is on the clinical side, are we going to move to screening these patients? And what's going to be the implication of doing this? Also, there's increasing interest on the discovery side. It's not yet on the clinical side of other types of exposures. And I think Dr. Jarsa is going to talk a little bit later about these exposures, the exposures of the 9/11 firefighters. And I come from the Department of Veterans Affairs, where this military toxic exposure world is exploding for us with a pressure on us to be able to say, not just that you were exposed and you're getting benefits, but I think our patients are saying, I'm exposed. What's the impact on my health? And what are you doing about it? And I think there's a lot of discovery that can be done about these exposures. We know the environmental backgrounds, certain things like petroleum, benzene, radiation. Well, these are things that the people in the military are exposed to at much higher rates. And are we seeing differences? So that in that discovery pathway, we'll move forward in doing that. And sort of the other side of it is then do we have to think about what's the potential for moving down this pathway of sort of intersecting therapeutic pathways to halt or revert what could be progression to that disease as we begin to discover these patients. So, and there's problems in doing this. Many of the mutations that we see in CHIP are loss of function mutations, and or they're epigenetic and transcriptional ones that we know already are difficult for development of drugs. And I think we all fall back to that sort of paradigm that we had of what happened with CML, a discovery of a genetic marker where we had a targeted therapy that could suppress it. And we've taken a drug, a universally fatal disorder when I was starting hematology, and turned it into one where a pill is controlling it and keeping the disease under control. And I think in the mind of targeted therapy, in the mind of people that went into it, as we began looking for these targeted therapies, people had the hopes that this would be there. And I think, at least in the world coming, I think many people, when they hear about our new immune and targeted therapies, there's the hope that we're heading in that direction in moving forward. And so it does bring up the issue, of the difficulty in doing this, and also the difficulty of even doing the trials and stepping in, because safety always trumps the efficacy. And many of the drugs that we use right now to treat these malignancies, and some of them that move into as we move into trying to get it into into the sort of preventive mechanisms, we really have to balance these risks moving forward. We don't know, for instance, if the clone that we target and affect will lead to other clones coming forward that this clone has been suppressing, or has been the dominant one, and when we wipe out the dominant one, another clone will move forward. And just if we can move to the next slide. It's also thinking of, when we see this clonal hematopoiesis, what are these patients really dying of? They're dying of cardiovascular disease. And if we look at the studies that have been done and look at the risk of having a clonal hematopoiesis is up there, higher than most of the reversible factors that we have in place. And again, what's causality? What's a driver? And what's the associate? Is it just some passenger or a association that exists that we with CHIP that's driving? Is it driving this, or is it just there in the background and not any different from the inflammatory markers that we already know exist of high ferritins and CRP that's there? And is there any ability for reversibility of that? So understanding the biology behind it is going to be a critical driver in moving forward, and also open up opportunities. The CHIP is, as they said, broader than we may think, in not just malignancies and hematologic disease. We own it because it's the blood cell. It's the organ you can biopsy every day. It's ours, but at the same time, it has broad implications in moving forward. And finally, sort of the last slide, and I'm trying to keep doing this rapidly, trying to keep up aware of the time, is that, what's the clinical clinical issues with this? It certainly is one. I know there's been I heard someone say earlier, get rid of the indeterminate prognosis. But a clinician having to explain this to a patient who's sitting in front of them thinking that they're dying of a disorder, that walking them back saying it's indeterminate prognosis, like Mungus is monoclonal gammopathy of unknown significance, and that is common in the elderly, and that it doesn't have this risk, are the things that have to be conveyed to the individual patients moving forward. And is there going to be any impact other than trying to decrease the risk of cardiovascular risk that occurs, that's really going to impact the real outcome that we want, which is decrease in mortality in these patients. And then finally, the last bottleneck, because as a hematologist, this slide was made a decade ago when we began the precision oncology program of profiling tumors in the VA, and I don't think it's changed much since that time. In fact, it may have gotten worse. Is that hematologists and oncologists are sitting here being swarmed. The clinicians sitting across from the patient are being swarmed by, am I doing the right test? Does it have all the information I want? Have I covered everything? The field is changing so fast, and the drugs are coming out, and not knowing, new drugs, we run risk not knowing in the real world what those toxicities are. So there's pressures on us as clinicians to be able to say to say what to do, to know that we have all the information that we need. Then we have to know that it's accurate, and we have to know how to implement it in the healthcare system, and really what's actionable, and really providing our clinicians not only with the information about the mutations, but also what's actionable about them, and assisting them in taking care of patients. So, with that, there's lots of clinical issues to be addressed moving forward in this field. But I'm thankful to BLOODPAC for pulling us together, because the most important thing is you can't have a biomarker unless you have validated and implemented in the clinical side, without everyone working together to find out and to create the knowledge needed for the clinicians to sit across from patients and give them their prognosis. And next slide, my final slide, is just to say thanks, and the hopes of our patients moving forward is that someday this will potentially happen. So I'll stop there.
Thank you so much, Mary. Love what you're doing. I wonder if the indeterminate potential part can be removed with better risk scores. Your talk emphasizes all the benefits of the
Yeah,
yeah,
yeah, I know.
Yeah, so you can,
You know, in discussions, it is difficult, right? So.
yeah, it is difficult. So I think a good question later that we can discuss might be, what it takes to make a reliable chip risk score. And if there's a future world where, without the negative implications of the word blockchain, if there's a world we actually, accumulate all this data and actually make better risk scores and help patients in that way and what it takes to get there. So thanks so much, and a big round of virtual applause for all the speakers. Wonderful work.
Hi, Dwayne. Thank you. And thank you all the speakers. That was just outstanding. So my name is Jim Godsey. I am a proud inaugural member of BLOODPAC, fellow co-chair. I'm also the Chief Scientific Officer and VP of R&D for Molecular Genomics and Oncology at Quest Diagnostics. So it's my true pleasure to moderate our panel discussion on these exciting new frontiers topic, beyond the noise, chip in liquid biopsy and clinical care. And to ensure we have a rich discussion on this growing area of research, we've assembled a stellar panel of industry experts, including bioinformatic experts, computational biologists, clinicians, and data science. So we have about 30 minutes left. I would suggest we try to do 5 minutes per a panelist question. And so the first question will go to Dr. Marissa Juntila, who's currently a lab and medical director at Garden Health. Marissa earned her MD and PhD in immunology at the University of Pennsylvania and completed her residency and fellowship in hematopathology at Stanford School of Medicine. She has over 10 years of experience in the diagnostic industry. So Marissa, welcome to the panel. I actually have a series of questions for you, beginning with when and where do we need to be certain that we're filtering out chip variants from our clinical ctDNA data? Anne did a great job, but maybe to recap, what are the most optimal methods for accomplishing this task? And specifically, do different intended uses dictate different methodologies? So Marissa, I'll turn it over to you.
Thank you. And I do appreciate the invitation, and the speakers gave a phenomenal overview and deep dive into chip. So I do agree that there should be some chip filtering, because we see a lot of variants, especially in the elderly and anyone who's been exposed to environmental stress, chemotherapy. This is obviously the patient population that is served by liquid biopsy and solid tumor testing. Two of the big areas that are thought about here with chip filtering are either algorithmic based approaches or Buffy code, or which is PBMC based approach filtering of chip. And I think they are part and parcel of very much the same path of during assay development. So you will most likely need to do Buffy code sequencing, and at some part during your development, depart away from Buffy code when you have developed enough of a database to understand what chips looks like on your assay. And so I think, developing an algorithm requires large data sets, a lot of experience, varied patient statuses. And so this is not always accessible to smaller laboratories, and Buffy code sequencing may be the way to go to filter out chip. And the third part of that is actually the tissue information that is important for chip filtering, which is not always available in a perhaps reference setting or liquid biopsy setting. So all of those approaches will require some type of plasma only approach, in my opinion. So I think other parts of your question, when do we need to filter chip in the clinical setting? So in solid tumor biology, we obviously see different driver mutations from the hematologic mutations that are characteristic of chip. And so in solid tumor mutation testing for therapy selection, I don't think chip is so much of an issue, as well as incorporating these chip filters into a therapy-based approach. But in the other settings, such as MRD or therapeutic monitoring, you may need to have a more sophisticated chip filter or add on additional layers, such as methylation-based approach, or depart from mutation-based signatures. So those clinical settings, obviously your assay will need to be validated in those clinical settings. And it's important to really consider how chip and how these, not just hematopoietic variants, but variants that are derived from other clonal outgrowths in other tissues that are circulating in the DNA.
What about limit of detection, optimal limit of detection for ctDNA tests for chip variants? What are your thoughts?
If you were to actually annotate ctDNA chip variants, is that what you're saying? You would actually provide a limit of detection for your assay. This would be much like all other biomarkers. You would analytically validate your ctDNA assay for the chip variants and determine what the limit of detection is. I think we would see you would need to filter out your analytical variants and clinical variants as well.
Very good. Thank you so much, Marissa. So next question is for Dr. Justin Finkel, who is currently a senior bioinformatics computational biology scientist at Precede Bio. Justin earned his PhD in biology at Northwestern University, and prior to joining Precede Bio, spent time working at Tempus on their ctDNA platform, and pertinent to this topic, working at 1016 Bio, the first company to leverage CHIP to discover novel targets for therapeutics that are target age-related disease. So Justin, we heard from Marissa about standardizing bioinformatics methods on filtering chip variants, treating them as a source of biologic noise, removing them from the final patient report. I loved your work on leveraging CHIP to discover novel age-related drug targets. Can you briefly explain how this worked? And I think it's interesting that it seems that your work would require that we maintain access to CHIP data versus removing it.
Yeah, thanks, Jim. It's fun to see everybody sort of assembled here and attacking CHIP from a bunch of different angles. At 1016, we had a great team working on sort of putting together and identifying and understanding chip biology, which is sort of the flip side of removing it as a noisy variant. And hopefully we as a community can all, work in harmony together. But one of the first steps underpinning this, and going back to the LOD question, is like, how can we reliably and sensitively detect chip variants? And there's a couple layers to this, is like, what is our definition of a chip variant? How do we distinguish it in a liquid setting that we heard from Alex and Anne and some of the other speakers? And then how do we categorize and mix that with all the clinical information? And so at 1016, we had to go through this process in a number of different data sets, some of our own proprietary work and some publicly available data sets like UKB. There's a big question first of like, does an individual have CHIP? And how do we distinguish between the different types of CHIP? Because DNMT3A and TET2 and ASXL1 CHIP are not all created equally. They don't have the same implication for disease, for complex disease, for oncology. And we were really focused on one, identifying CHIP in individuals, and two, identifying how we could figure out what the therapeutically relevant indications are and subsetting patients and doing all of that discovery biology. That's a brief overview of our work at 1016.
So what would be some examples of possible drug targets for an age-related therapeutic?
So I think Alex, did a great survey of sort of the space in cardiovascular disease. I think a lot of things that we're exploring at 1016 were focused on how do we identify the transition through some of these other MPNs that people have discussed. So how do you go from CHIP that is just existing at baseline towards a transition to CCUS or MDS or full-blown AML? And there's a number of different approaches that you can take, sort of mixing somatic information, so high quality somatic detection, with germline genetics, and how can we identify sort of a germline predisposition for response to treatment or likelihood of transitioning to a more severe case of disease.
So Alex, Dr. Bick, would you like to weigh in on that a little bit?
I'd just say, broadly, and Dwayne had mentioned this, I think, as well in one of his remarks. You can think about targeting the driver mutation in CHIP, or you can think about targeting something else. And something else could be, inflammation, if you're think that inflammation might be contributing to either the clone expanding, which is sort of the basis of the canakinumab study that Umar Barate is leading, or you might think that inflammation is leading to heart disease, liver disease, whatever other sort of evil humors that the CHIP clone is producing. And so I think some of those kinds of trials are going to launch in the next year. Either some are investigator initiatives, some are industry sponsored. And so I think, again, they're exciting hypotheses, and the only way to test them is by doing the clinical trial, because we've already done it in mouse. We've already, looked at sort of historical data, but ultimately, we need a randomized trial for some of these questions.
Very good. Thank you,
I think
Alex.
that's exactly
Thank you,
right.
Justin. All right, so now let's shift our focus from drug targets toward clinical implications. And this series of questions are for Dr. Sakshi Jazra, and she's an assistant professor of medicine at the University of Vermont Medical Center in the Department of Hematology and Oncology. Her clinical research is focused on studying the impact of environmental exposures on progression of clonal hematopoiesis. And she's published research examining the burden of clonal hematopoiesis in first responders exposed to the World Trade Center disaster, which is fascinating. So Sakshi, I'll turn it over to you, but the series of questions is, how should we handle incidental findings of CHIP mutations and liquid biopsy assays? Should we report it or not? Do physicians want this information? Is it actionable? Some liquid biopsy assays do not have all the CHIP genes. Do clinicians need, in fact, know this? So glad to repeat any of those, but love for you to weave in your research on environmental factors.
Yeah, so, to take a step back, I think in order to be able to answer those questions, we need to remind ourselves that we're really talking about two different groups of patients with clonal hematopoiesis. We're more commonly talking about the patients with the known malignancy, which, we tend to think of solid tumors, but certainly heme malignancies like lymphomas and multiple myeloma patients can also have clonal hematopoiesis. And we're conducting liquid biopsies as a way of either diagnosing or looking for an actionable mutation that we can then you have this other group of patients, which is what we had explored in our WTC cohort, where we think that either they're healthy and have no clonal or other cytopenias, or for whatever reason, if there's been an environmental exposure or an occupational exposure, such as for our veterans, we think that they may have an increased risk of developing a heme malignancy and potentially even clonal hematopoiesis at baseline. So how you approach these two groups of patients can potentially differ a little bit. I think, the question of should the CH be reported, to me, is the more simple one to answer. In my opinion, I think, there's a plethora of data showing that there is an impact on overall survival. We know that these patients have an inferior overall survival. We know that there's an impact on cardiovascular mortality. So yes, we definitely should be reporting CH. How we should report CH, I think, is a little bit more difficult to answer, and we, that depends on how the testing is conducted, whether there is paired tumor and white blood cell DNA testing that's done, and how accurately we're actually reporting these variants. Reporting of these CH mutations will allow the clinicians to be able to monitor them in a longitudinal manner. I loved what Mary said earlier, that the blood is the easiest organ to sample. You can do it, every day if you really wanted to, and really determine if there is clonal evolution. Are these patients starting to develop cytopenias over time? The really difficult question, in my opinion, is this actionable? And I would say that even though we have data to show that these patients have inferior overall survival, all of the studies actually show that patients are more likely to die from progression of their underlying malignancy rather than clonal hematopoiesis. In the paper that Amit had actually mentioned, that was done back in, I think, 2019 with Callie Coombs at MSK, even though that study showed that patients had an inferior overall survival, 98% of patients were dying from progression of their underlying malignancy. So the risk of actually dying from CH is very, very low. And the absolute risk of developing a heme malignancy is, again, on the order of about 0.5 to 1%, which is comparable to what we see with MGUS or MBL. So why this occurs, I think, again, is difficult. Could it be the hyperinflammatory phenotype of clonal hematopoiesis, or is CH sort of a biological marker for fitness in the patient? I think that still needs to be parsed out. So in my opinion, in order to be able to move this field forward, what we really need are two things. I think we need to define what constitutes high-risk clonal hematopoiesis. There's groups that have said that if you have more than 2 mutations in kind of the canonical CH genes, which is your DNMT3, TET2, ASXL, and JAK2, or TP53 and PPM1D, if you have more than 2 mutations, if the VF burden is higher, or if the patient has cytopenias, then that's something that we should be addressing. But again, there's no consensus, and I think validating and constructing the CHRS risk calculator that we have in our cancer population would be a really great step to be able to provide clinicians with the data that they need to counsel patients and really empower them to have fruitful discussions. But to say that, should we be modulating our adjuvant treatment in our cancer population based on the presence of CH, I think is a little premature, especially if we have data to show that these patients are more likely to have progression of their malignancy rather than true therapy-related neoplasms.
Outstanding. Thank you so much. Mary, would you like to weigh in on a couple of comments on that? I know you commented during your talk.
Sorry. No, I would add, it is coming down to the point of how do we get a better risk score for these individuals and pull out I totally agree with that is on a clinical side, the most important part of this, to be able to understand this. And I agree that, they are different populations, and looking, inflammatory is an important driver of inflammation, or at least the inflammatory side, may be one of the most important pieces of this driving everything, but the understanding behind it is certainly lacking, and I think it still remains on the discovery platform side. I agree it's not ready for prime time to start screening patients and denying them of adjuvant chemotherapy. We need a better understanding of this. Again, take into consideration that these patients that have tumors have already declared themselves as having malignancies, and the clonal hematopoiesis in the background, its relationship to the existing malignancy, even hematologic, is unclear. Whether or not the clone itself is arising from that clone, or a new aggressive de novo clone appears in causing the disease. So lots of discovery to do before we can fully understand how to implement this. I do agree also that we do need to inform patients when we see it, but inform them in a way that de-escalates the usual situation of, I have a marker, they're told they have immunophenotype of CLL, and the family and patient comes in the door expecting that they're going to be told they're dying, and you have to walk it back to a early marker, and that's not an uncommon feature in clinic when these markers are out there and being used clinically.
Okay, so Mary, Sakshi, thank you so much. Outstanding response. And then finally, a question for our own Bob Grossman, who is the Frederick H. Rawson Distinguished Service Professor in Medicine and Computer Science, and the Jim and Karen Frank, Director of Center for Translational Data Science at the University of Chicago, and as I stated earlier, the architect and leader of the BLOODPAC Data Commons. So Bob, as a direct result of this new frontiers presentation on CHIP and its clinical implications, what are your thoughts on BLOODPAC's interest and ability to create a repository for CHIP data within the existing BLOODPAC data commons? And what are some of the obvious challenges we would expect to face should we take on this challenge?
Well, thank you. It was a pleasure watching the talks today. This is clearly an area of important interest for the BLOODPAC community. It would be, from a technical viewpoint, straightforward to bring in CHIP data to the BLOODPAC data commons if there was member interest in that. There are a number of simple things we could do. There's no standard location for community data sets around CHIP data, and the BLOODPAC data commons could do that naturally. In other areas, we've worked as members working together pre-competitively to agree on data elements, minimum technical data elements, to get a community consensus when new assays are collected. We could do that here. The last several years, we've done projects when new assays have entered to look at variability across labs to help our members and to help our sponsors, both with contrived data and more recently with biological samples. Things where risk scores and other things need a critical mass of data from member-generated data, member-contributed data might also be a natural fit. So, I think one of the strengths of BLOODPAC has always been, individual members sometimes come up with ideas, but generally nothing is done without a consensus. If there is a consensus to create a repository, more accurately, a data commons for CHIP data, not only could we do it fairly easily, but it would also fit in naturally and could interoperate with other types of data platforms out there now. This is especially important for environmental exposures, for cancer, and more generally. Mary Brophy and a number of the other, several of the other speakers have talked about that. BLOODPAC is involved in the the Prometheus project, where we're looking at cancer and environmental exposures. And so I think for all those reasons, this would be member driven, and it's something that I hope the BLOODPAC members think through. But for me, it'd be a very exciting opportunity. Again, I was very impressed by the talks I heard and the potential in this area.
Bob, thanks so much. And that's, the concept of a data commons for ctDNA, data is something that was established early on with BLOODPAC, and I think it's really had a tremendous impact on the research community and bringing these assays closer to, the clinic. So thank you for the work that you and your team have done. So now it's time to pull one or two questions from the chat. I saw that you guys are doing a great job responding, but the one question that we didn't get answered yet was Dwayne's original question, which is, and it was for Alex. So Alex, are we at a stage where thinking about the societal cost of CHIP makes sense in terms of excess risk of cardiovascular risk, including stroke plus heme malignancies, tangible healthcare costs, less tangible productivity costs, with the caveat that not all associations are necessarily causal? Are there gains to be had in drugging CHIP? It kind of gets back to Justin's topic, and then I will add, and as we think about drugging CHIP, are there really some considerations that we need to think about from designing clinical trials for this topic? So Alex?
Yeah, that's great, and I'd like to spend the next 2 hours addressing the question in detail. I think the key is trying to think about this paradigm of precision medicine, which is really what BLOODPAC is working towards on the solid tumor side, and that if you can identify a small enough subset of patients that have a high enough percentage of risk, and treat them with a drug where the benefit from that drug outweighs the the harm and the side effects from whatever the medication is, then I think the answer is absolutely yes. I think the next question is, are we there yet, or how close are we? I think probably the place that we'll see benefit first is in the the nearly MDS space, the CCUSs of the world, where we have patients who are at very high risk for transformation. They have, they may even have disease burden, or will soon have disease burden from susceptibility to infection. And, if there's a highly targeted therapy that, works well to address the specific mutation, or even if it's an anti-inflammatory drug, that is reasonably well tolerated, I think that's probably where we'll start with trying to define these clinical trials. I think where, again, efforts like BLOODPAC are crucial, though, is in finding those patients. And so, Anne can query, her database and find some set of patients with CHIP. All of the other, liquid biopsy companies have, have similar lists. And so trying to match, the right patient with the right clinical trial for something that we're not really routinely testing for, is going to be a challenge to overcome. And so that's also why I'm very excited about the thought of a data commons where, even if you don't know who the patients are, at least to know that, such patients exist and what, what the prevalence of, of these mutations are is going to be really critical. That's my
Thanks so much, Alex. Thank you. So I want to now, close out our panel discussion by thanking amazing panelists. So, Marissa, Justin, Sakshi, Bob, just an incredible job. Thank you for your thoughtful and insightful responses. And now as we kind of wrap up, we wanted to spend a little bit of time in this remaining section about, what are the contributions with regard to chip standardization for ctDNA test development or clinical implications of chip findings? Do we think that our academic, our diagnostic, regulatory, pharma industry members would want to see BLOODPAC focus on? And think about, what could be helpful to the liquid biopsy and medical community at large? What type of project could we create? What will people contribute to? How would it move forward? What would the deliverables be? And just to kind of plant a seed, some thoughts on possible contributions we might make could be member consensus on validation methods and our standards for use for validation. Contributions by industry partners of matched tissue data or contrived data sets to the BLOODPAC data commons that could serve to drive future translational research. And then finally, creation of a normal negative control data set for use by ctDNA test developers. So would love to hear your thoughts, and please put it in the chat, email us, and we will definitely follow up and get back to you from at our next quarterly members meeting on this topic. So Lauren, I'm going to turn it back over to you to take us home.
Well, I think Anand also, I think you raised your hand and you may still have a question.
Yes, thank you for convening this meeting. Actually, I think it's very timely and this is a very important topic, right? And I'm a little concerned personally. I'm from the FDA, Center for Devices, Division of Molecular Genetics and Pathology Medical Officer. And I'm a little bit concerned about chip signal, contaminating the MRD signal and MRD assays, which may be very promising in the solid tumor space. And, the thing is that it's a little bit expensive for companies to do the Buffy code sequencing. Some companies are doing the Buffy code sequencing, but they're not doing it at a great depth, right? They're doing it like 150x. I'm not sure if that's enough. So I sort of am interested in determining what the best standards are for dealing with chip contamination of MRD signal. And I'm wondering whether the algorithms that are being used need to be validated versus Buffy code sequencing at a high depth, or are there any other solutions to this issue of the chip contaminating the tumor signal? So I'd love to hear what anyone has to say on this topic.
Yeah, so I'll just start, and Anand, thank you as always for an insightful question, and we could certainly see that this could be something that could be picked up by the BLOODPAC's MRD working group. But as you think about, most of the tests today are tumor informed, then I think you're suggesting, can we beef up the depth of the normal portion of the tumor normal for content, development,
right.
And make sure that when we do identify, variants that go into whether it's 16, 48, or 50, variant size panels, that they're truly the somatic variants and not chip. And,
yeah, so there,
I would say it's still early days in the industry, and we probably have to perfect that.
So if it's tumor informed, right, there's a little bit less likelihood of contamination with chip, right? But it's not completely eliminated, because you can have lymphovascular invasion of tumor tissue, right? So that's something to consider.
Oh, absolutely.
I think it also comes out in studies like TracerX, where you look at the false positive rate of recurrence, and that also gives you some signal as to, how much, whether the thresholds that, companies in the space are using for their background are sufficient, because you'd envision chip being background. I mean, in defense of the tumor-informed companies, they have been very proactive, I think, about chip. And, if you look at, like I said earlier, TracerX, that data, I think, gives us a sense as to how confident we can be about that data, and that's probably a longer discussion than we could have in 5 minutes, but happy to chat offline.
Sure.
And
I'd like to just say, this is Don, that with some of the new developments in sequencing technology, like the NovaSeq X Plus platform, for a lot of application, that's going to drop the cost of sequencing by 80%. So for instance, I can do a whole genome here in Little Rock, Arkansas at 30x coverage for $1,000. With the NovaSeq X, I can do the same thing for 200. So that can change everything, and should be considered, because that's being introduced now. And there's nothing like more data in this type of an application to convince yourself statistically about what you're seeing.
Yes, I agree. We need more data. And Anand, I mentioned that we can also, depart from the variants as our method of detection, and use methylation signatures, which also can be trained on the tumor of origin type of assays, which can help alleviate that pressure on chip. And as I mentioned before, chip is although it's seen throughout the genome, it's not well characterized within the driver genes in solid tumors that we are using for MRD. And for this liquid tumors that have MRD analysis, we have the antigen receptors to follow.
Right. I would just say the other thing that this platform, the NovaSeq X, it gives us longer read lengths. And so that's going to give us a lot more specificity with the alignments. And so that's also something that's quite important.
So
I think this point that Anand raised real quick is very important it could be a very important topic for BLOODPAC to pick up on as well, and maybe sort of work towards methodologies and harmonizing the data that is being generated. We talk a lot internally around how chip might be confounding molecular response results and MRD results. And, as Anand mentioned, it becomes an expensive activity to sequence to Buffy code, but that seems to be currently the best way of handling chip variants. And so how do we move on to actually using algorithms to identify these mutations and removing them with high levels of confidence so that we know the data that we're getting back from patients in these trials is actually going to be useful.
Yeah, thank you for echoing my sentiment. Yeah.
So I love that Don spoke up because 6 years ago, Don wrote the first paragraph in our forward on ctDNA generic protocols about we'll say the potential problems we were going to bump into with the chip as a source of noise in ctDNA tests. So thank you, Don.
Quite welcome.
Good point.
Lauren, take us home. You're on mute.
So muted. All right. Thank you everyone for attending today. I'm really thrilled. I just want to remind everyone just one last time why we're really here. One, we want to inform everyone. I'll give you guys a little bit more background, which I hope we did today on CHIP and where the status of it in our community and what we're able to do and potentially contribute as BLOODPAC. The big question is there anything that we are able to contribute to the community, something concrete? And so I just want to let everyone know that we will be posting this video, so feel free to circulate the link on our website in the next few days. And we will be taking all of your questions as well as an overview of the discussion. We're creating a white paper on it over the next couple weeks, and we'll be posting that along with that video on the website in the next few weeks, probably by year end. The idea is, do we or do we not want to start a working group around CHIP? If you guys feel, positively or negatively in any which way, please always feel free to email me directly. Happy to receive that feedback. And I just want to give a tremendous thank you to all of our speakers who spoke today, all of the panelists that participated, and again, a huge gratitude and just really amount of time that Jim, Dwayne, Bob Tell, I feel like you're on here somewhere. I don't know where. I can't see your picture. Those three individuals put a tremendous amount of time, energy, and effort into thinking through who we were going to have speak and the topics we were going to address. And once again, Medea, huge thank you to you for helping us organize this. And with that, I feel like we're 30 seconds ahead. I will give everyone back those 30 seconds of time. Have a wonderful rest of the week, and we look forward to seeing you again soon. Thank you.
Thank you.
Thank you.
Thanks, everyone.